Good evening, friends. It's a warm welcome from my side for this new webinar on a difficult topic, in a sense, though it is a very common topic that we have to deal with. But before we start that, Fact Tech team, can you please display the slide? Yeah. Dr. Atri Gangopadhyay recently lost his father-in-law, Mr. Deepak Debroy, and from the entire CCI Council, Krishna Anna, and the entire CCI Governing Council, as well as the entire CCI family, we all pay the tribute to the soul which is departed. We are there with you, Dr. Atri, in this sad moment. And we'll all be following a 15-second silence. Thank you very much. May God bless the soul. So can we move on to the topic today? And our topic of discussion is very interesting. We have diabetes and lung infections in focus today. And as we know that pulmonologists do not do very well with diabetes, so we need a very important external help. And the first important resource person that we are going to utilize today is Dr. Samantha Sathyakumar. She is MD and DM in endocrinology. She is a consultant endocrinologist in Apollo Hospitals, Jubilee Hills, Hyderabad, since 2018, if I am not wrong. And she is a dear colleague of our Dr. Vijayana. So she'll be there to guide us through today's discussions. And whenever it comes to a tough decision, then we will have her expertise available at all times. Let me introduce the other faculties. And what the structure that we are going to have is we'll be having 4 back-to-back talks in the beginning. We will be starting with Dr. Suryakanth, if I'm not wrong. And his talk is about, he's from Hyderabad again. Dr. Suryakanth is from Hyderabad, I guess. Dr. Raghukanth, I'm sorry. Dr. Raghukanth. Yeah, and welcome, Dr. Raghukanth.
Yeah, thank you.
Your talk is will deal with TB and diabetes. Then we'll have our champion presenter, Dr. S Jayaraman. We have already seen him recently, and he needs no special introduction as such. And he's a wonderful orator as well as very outgoing personality. And he'll be speaking on the fungal infections, if I'm correct. Yeah. Then we have the only lady, or rather, the amongst the panelists, of course, we have the expert lady here, but Dr. Devi Jyoti Dash, she's from Raipur. She's an assistant professor in the Raipur area, and I think she's going to talk to us about various pneumonias, that is community-acquired pneumonia, hospital-acquired, as well as ventilator-associated pneumonia, and the linkage to diabetes. Let me reiterate that today we are celebrating diabetes in a way, because all the topics have to do with diabetes. And last but not the least, somebody closer from my state, from Mumbai, the capital city, Dr. Saurabh Mandilwar. He'll be talking to us about COVID-19 and the diabetes and its association. And with that introduction, I will request the tech team to go on and start the first presentation, which will be from Dr. Raghukanth's side. And we'll go through all the presentations, and then I will be asking questions. And I'm sure Shailaja madam is ready with the answers in any case, because I have very, very little answers. So mostly we'll be asking her the questions. Let's see, however it goes. And it's going to be a very interesting session. I welcome you all to that. And over to the first talk, please.
Hello everyone, this is Dr. A Raghukanth, a consultant pulmonologist, KIMS Hospital, Gachibowli, Hyderabad. First of all, I need to give a thanks for the CCI team to giving this opportunity to discuss about the most commonly encountered diseases like diabetes and tuberculosis combo. First, initially, I'll tell you the case details about the diabetes and tuberculosis. Then I'll highlight about the combination incidence and prevalence and review article, few conclusions. So going back to details, a 51-year-old male presented with a fever and cough with hemoptysis over 1 week and one bout of a moderate quantity. Had a history of diabetes over 3 years on medication and past history of tuberculosis in 2021. It for 6 months of ATT. Whereas the old X-ray showing clear-cut left upper lobe cavity with air fluid level and a small infiltrate. So on arrival, he found a mild tachypneic with SATs of good 99 on room air, but bilateral crepes were noted on the auscultation. This is X-ray on OPD where it was clearly left upper lobe fibrotic patch with cavity and a mild effusion noted. So initial other workup were done to rule out the active in view of active hemoptysis, the APT normal, platelets were normal, and the viral and RFT were normal, but HbA1c were high, uncontrolled. HbA1c 11.2. Advised CT chest in the view of moderate quantity of bout of hemoptysis, which clearly depicts the cavity with effusion and nodes, and also a micronodular infiltrates over in the lung field. So it started with broad spectrum antibiotics, cough suppressant, supportive, and once the stream of test is controlled, then we advise put over AB and gene expert, which turned out to positive, even the MPB detected, but there's no rifampicin resistance. So initiated 4-drug regimen as per body weight, and discharged with a follow-up in the OPD is good, doing good, febrile, but after initiation of 1 week of ATT, there's extreme weakness, nausea, vomiting, and advised LFT, then uric acid levels were increased. Abnormal LFT, ALT, and ST increased. So he developed a DAH, that is drug-induced hepatotoxicity. So initiated modified regimen to stop all the hepatotoxic drug, continued only ethambutol and levo. Later added slowly with one drug with isoniazid. Later continue with restarted the rifampicin. But within 1 day, one dose, is severe intolerance and left deranged and not tolerating the rifampicin, so stopped. So continued only HE and levo, and initiated a paracetamol, but again he started the severe pains and uric acid levels were elevated. So initiated a streptomycin 4-drug regimen, but is not accepting in the way of daily or alternative injectables. So he continued isoniazid, ethambutol, levo, and slowly followed. Continued in between, he had some problem because of hypoglycemia and one more is a traffic accident, but he's doing good with the present medication. And later on last week he came, he stopped the levo and restarted with rifampicin. These are the serial X-rays of the progression of the disease. This is the initial X-ray, the left hand side. Later he developed effusion, but there's never tachypneic or breathlessness, so never aspirated. Continued the ATT and good diabetic control with the diabetologist, and slowly there's a complete resolution of the cavities and the effusion. This is the initial X-ray, the latest X-ray in the last visit. There's good improvement in the overall. He's complaining of mild pain, so arthrology workup done, and his diabetic was good control. HbA1c was 5. So coming to facts of the tuberculosis, tuberculosis 1.3 million died in TB from 2022. Fell ill with tuberculosis about 10 million, 10.6 million. Whereas diabetes and tuberculosis combo will always increase the risk. That is twofold risk of TB disease because of the diabetes, twofold risk of death during treatment, fourfold risk of relapse. That is in my case, which has happened. Twofold risk of the MDR TB. Coming to the aspect of the risk factors of tuberculosis, more prone for pulmonary infection. The diabetes is one of the most common, but particularly uncontrolled diabetes. The more susceptibility in case of a hyperglycemia or diabetes patients is mainly because of the hyperglycemia-related impaired immune response and vascular insufficiency. There is a good systemic and review and meta-analysis which clearly depicted study found that quarter of TB patients in South Asia has also have a diabetes comorbidity ranging from 11 to 24%. It's not only on the development, but also its impact on the comorbidity and the treatment and mortality failure. So this is always useful to screen, comprehensive screening like HIV and TB is always to have early diagnosis and treatment of diabetes among the TB and vice versa. The same thing, meta-analysis systemic review, which published in December 10, 2021 by Joseph Rogre and et al., which clearly depict the developing latent TB and active TB, but much more in these investigations needed to by which the diabetic increased risk of TB were needed. To conclude my talk, the early diagnosis, early treatment is very crucial, and vice versa, screening of TB patients, diabetes and diabetic patients to screen tuberculosis is needed, and strict diabetic control needed to prevent the relapse. And lower zone TB, especially in background of non-HIV and non-immunosuppressive drug, will always relate to diabetes. I'll give a classical example of railway track to my patient, those who are on diabetic and TB. It should be go smooth parallelly so that you will have a better outcome. Thank you.
Good evening. Namaste. I'm Dr. S Jayaraman. Thank you, CCI, for this wonderful opportunity to present in this August gathering. Respected CCI founder, Dr. Krishna sir and Narayana Pradeepa sir, and the CCI President, Dr. Ashish sir, and Secretary, Dr. Anil Maske, CCI Webinar Coordinator, Dr. Vijaykumar sir, and Atri and other stalwart CCI leader, Dr. Kirat, Dr. Shivani ma'am, Nitin sir. Good evening to all of you. So now I am going to present pulmonary infections in diabetes. My topic of presentation is the diabetes and fungal infections, that is pulmonary mycosis. Diabetes mellitus and pulmonary fungal infections. Diabetes, India is a world diabetes capital. Diabetes mellitus is an important risk factor due to impaired innate and acquired immunity for the opportunistic fungal infections like candidiasis, aspergillosis, and mucormycosis. Pulmonary mucormycosis, although is a rare presentation in a diabetic patient, but is associated with a high mortality and morbidity. The mucorales fungi are responsible for mucormycosis with rhizopus, mucor, and rhizomucor organisms, often being responsible for the human infections. This is the case scenario. This is a classical presentation we come across as a pulmonary physicians. So old PT patients, because of uncontrolled diabetes, they present to us with a hemoptysis. This is a classical presentation. The left upper lobe predilection of the lesion characterized by the very classical cavity. Within the cavity, there is a solid lesion. This is very classical of fungal ball or aspergilloma. So this patient usually present with the recurrent hemoptysis, mild to moderate or massive both, because of the invasion of the fungal colonization into the erosion of blood vessels can cause hemoptysis. So the treatment of choice is the surgical lobectomy. If the patient is not able to do the surgery, so we can give some medical treatment, itraconazole, 3 to 6 months course, and see this patient, and we will control the diabetic status, etc. So this is a very common scenario we come across in our practice. The commonest etiology of fungal ball, you all know well, Aspergillus fumigatus. The inhalation of spores, the spores which leads to colonization in the airways, which causes, depends based on the immunity level. It colonize and grow well, and it form the mass lesion. Already patient has a old PT, some cavital lesion, so it may grow as a fungal ball. So the classical presentation of is the uncontrolled diabetes with the old PT, hemoptysis. So how to diagnose apart from clinical radiological? This based on the sputum or tracheal aspirates or bronchial washings or tissue biopsy. In blood examination also we can find out. The test like histopathological and cytological staining, which can prove Aspergillus or not. And culture at the growth and antigen testing and nucleic acid PCR methods and beta-D glucan detection, so which will help in Aspergillus confirmation. So the treatment is surgical and medical management. The challenges what we are facing in Aspergillus based on the immune response. So this is Aspergillus fungus is one of the opportunistic fungal infections. There are interplay between the host and fungus which leads to the disease. Some of the time we have a diagnostic challenges. The biomarkers for Aspergillus is the galactomannan and beta-D glucan. And the circulating galactomannan may be positive 5 to 8 days before clinical manifestation, and sensitivity increases with the lower neutrophil count. You can see here this hypersensitivity reaction commonly we see in asthma, uncontrolled asthma or cystic fibrosis, which eventually leads to ABPA. And in a structural disease, plus or minus inflammation, which causes the aspergilloma. So what we had a case now. And in the case of severe immunodeficiency, which leads to invasive pulmonary aspergillosis. So other case is a 72-year-old male, non-smoker, hypertensive, steroid-induced diabetic and hypothyroid. Past history, patient had a COVID-19 pneumonia with severe ARDS in August 2020. During the first wave of COVID, he received antiviral remdesivir, methylprednisolone 40 mg thrice daily for 7 days, 40 mg twice daily for 5 days, 20 mg twice daily for 7 days, 2 doses of convalescent plasma and was given a rehabilitation care also. Tocilizumab was not given, discharged with a tapering dose of methylprednisolone from 16 mg. After that, patient developed streaky hemoptysis and patient's vitals are stable. With the hemoptysis, patient came to us. We did a CT scan which showed a 2.5 centimeter nodule noted in the right upper lobe posterior segment. So with the central cavitation and necrosis. This patient submitted for CT-guided biopsy, which then the post-procedure patient developed a minimal pneumothorax, which was conservatively managed with a high-flow oxygen therapy in ICU, and subsequently pneumothorax settled. Started on empirical broad-spectrum antifungal therapy, that is liposomal amphotericin B, 5 mg per kg per day. The histopathology report came as a broad, non-septate fungal hyphae with morphology suggestive of mucormycosis. Then posaconazole 300 mg per day was added as a combination therapy. Liposomal amphotericin B dose increased to 10 mg per kg per day as patient is not improving. This patient, we had challenging scenarios like requiring high-flow nasal cannula for several days. Patient was in a condition about to intubate. In that crisis between the post-COVID lung and mucormycosis, the CCU team had taken a daring decision, was taken to give methylprednisolone 125 mg stat and 3 doses of 40 mg methylprednisolone and manage the crisis. Patient slowly weaned off from oxygen support. PICC line was kept under the sterile aseptic precaution. Intermittent fever spikes were noted. Blood culture sent from PICC line revealed the growth of pan-sensitive Klebsiella, continued with the same antibiotic imipenem. During the course, he had a hypokalemia and hypomagnesemia and correction given. Also, creatinine level started rising and maximum was up to 1.52. Hyponatremia was also there. Underlying diabetes has been managed effectively. Repeat CT showed partial response as compared to previous scan. After 6 weeks, liposomal amphotericin B stopped and changed to oral posaconazole at discharge. Patient came for follow-up after 1 month of oral posaconazole course. Patient is doing extremely good. Literature review, novel perspective of mucormycosis, pathophysiology, presentation and management. The overall survival rate of patients with mucormycosis is approximately 50%. Although survival rates of up to 85% have been reported more recently. In contrast, pulmonary mucormycosis has a high mortality because it is difficult to diagnose. The other paper clearly shows that the pulmonary mucormycosis, of the 20 patients, there are study about 20 patients with pulmonary mucormycosis, 10 patients survived. Among the 9 patients who did not undergo surgical resection, only 1% survived. And other eight patients died within 4 weeks of the initial diagnosis due to pulmonary mucormycosis. In contrast, of the 11 patients who underwent pulmonary resection surgery, 9 survived and 2 died from ventilator-associated pneumonia on day 25 and complicated surgical wound infection on day 61 after the diagnosis. The take-home message from my presentation is early diagnosis and initiating treatment early plays a major role in effective treatment of mucormycosis. All pulmonary mucormycosis patients do not need surgical management if diagnosed as early as possible. Non-responders to conventional medical management can be tried with the high doses of liposomal amphotericin B. In a worsening fungal pneumonia patient, we should not think only in aspects of pneumonia. We should have a broader view in all aspects like multi-drug resistant Klebsiella growth from PICC line in this case. So the final concluding remarks is the diabetes and pulmonary mycosis are very common clinical scenarios. Apart from candidiasis, aspergillosis, mucormycosis, also we have seen a number of times. The etiology behind is the hyperglycemia, and which leads to less than poor immunity, immunosenescence, which invite fungal infections and causing these issues. So adequate diabetic control and early diagnosis are very important to success of these kind of pulmonary mycosis due to diabetes and other etiologies. So thank you very much once again, CCU team, for this wonderful opportunity. Thank you very much.
Good evening, everyone. I am Dr. Devi consultant pulmonologist from Raipur, Chhattisgarh. First and foremost, I want to thank CCI for giving me this wonderful opportunity. Nitin Abhyankar sir, thank you for the warm introduction. We already have 2 great talks by Dr. Raghukanth and S Jayaraman sir. Now we will be talking about diabetes and pneumonia, and we will focus more on community-acquired pneumonia and hospital-acquired pneumonia. So patients with diabetes mellitus have increased propensity of infections, and the risk of hospitalization and mortality is more. And the risk is more in patients with longer duration of diabetes and with poor glycemic control. Presenting a case report, a 55-year-old female with uncontrolled diabetes since last 15 years presented with productive green and yellow sputum for last 3 days. There was no hemoptysis or fever. The X-ray showed left upper zone and right lower zone consolidations with air bronchograms. She had to be intubated and started on norepinephrine infusion in view of persistent hypotension. The random blood sugar was more than 450. She was started on piperacillin, tazobactam, and azithromycin and other supportive treatment and was admitted in ICU. On physical examination, there were both inspiratory and expiratory crepitations. The initial ET suctioning showed green and yellow secretions, but there was no blood. The important blood investigations were the TLC count was 10,900, RBS was more than 450 with a lactate of more than 2. CRP was very high, 545, and the procalcitonin was also 43.56. The blood culture and sputum culture sent in the ER both grew Staphylococcus aureus, and hence vancomycin was added. On day 3, she began to require higher FiO2 and P. X-ray showed worsening of the lobar consolidations along with lucences suggestive of cavitation in her left upper lung fields. ET secretions began to turn reddish brown. CT chest was performed and it showed extensive pulmonary necrosis diffusely in both the lobes of the left lung and in the right lung base. CTVS opinion was sought and was advised a left pneumonectomy and a right lower lobectomy. However, she succumbed the next day. Over the past few years, the incidence of both CAP and diabetes mellitus has increased. Diabetic patients may not present with fever or typical features of infection. And MRSA pneumonia has a rapid deterioration, especially in diabetic patients. Now, we will discuss about a few studies related to a topic. So this is a systemic review and meta-analysis of type 2 diabetes mellitus and risk of community-acquired pneumonia, published in 2021. Though this meta-analysis has a risk of bias, it showed that type 2 diabetes may be associated with an increased risk of CAP. This is an analysis from India where they have reviewed the risk of community-acquired pneumonia with various comorbidities, including diabetes. They reviewed 2,265 patients, and they have shown that other comorbid conditions, including diabetes mellitus, are risk factors for CAP in the Indian population. This is another study published in BMJ in 2016, and it shows the effect of diabetes in community-acquired pneumonia patients who are hospitalized. So they have included 74,175 CAP patients, and they have shown that they needed more number of hospital stay. The in-hospital mortality was also significantly higher. Now we have already discussed about community-acquired pneumonia, and most of the studies showed that in patients of diabetes, there is increased risk and increased mortality in CAP. But this is not so for hospital-acquired pneumonia, as we can see from this study published in 2007. They have shown that diabetes mellitus is not a risk factor for development of HAP in patients who require ICU treatment, and also diabetes mellitus is not a prognostic factor for mortality. Now, this study studied mechanically ventilated adult trauma patients for occurrence of ventilator-associated pneumonia, and they have shown that the risk of VAC in diabetic patients was greater than non-diabetic patients after adjustments for other potential factors. This is another study published in 2017 in EJIM. They have studied the incidence, characteristic, and outcomes of VAC among type 2 diabetes patients. Most of these studies are population-based observational studies, and it was done in Spain. They have shown that the incidence of VAC was higher with type 2 diabetes mellitus patient. However, type 2 diabetes mellitus did not predict higher mortality in VAC. So the take-home message: diabetes mellitus has increased risk, severity, and mortality in community-acquired pneumonia. The association is not so clear in nosocomial infections. Incidence of VAC is high in diabetics, however, severity and mortality may not be high. Longer duration and high glycemia is associated with higher risk and severity, and hence strict control of glycemia is an important factor for prevention of infections. Thank you.
So good evening, everyone. This is Dr. Saurabh Mandilwar. I am consultant chest physician at Cooper Hospital, Juhu, Mumbai. I practice. So today we are going to talk about COVID-19 and diabetes. So we'll discuss about a study initially, and then later we'll discuss about a meta-analysis. So COVID-19 pneumonia increased insulin requirement in non-diabetic patients. This is the topic of this study, and this is a prospective observational study. This was done at Coimbatore. So this was single center study. COVID-19, is the disease which causes affection of multiple organs and multiple metabolic derangements. Insulin resistance and deranged blood sugar control due to COVID-19 have been major problems when managing diabetic patients with hyperglycemia. So we have seen a lot of patients with COVID-19 pneumonia in diabetic patients. So we have lack of literature till now, but till now, whatever studies are available, we'll discuss those points. So about this study, this is single center prospective observational study, which was done in tertiary care hospital. And the time frame was taken was June 2020 to December 2020. 75 patients were fair diabetic control were in study, whose HbA1c level was less than 0.75. And average daily insulin requirement was calculated for first 7 days of admission. So a subgroup analysis was also done to show the relation between severity of illness and glycemic dysregulation. So these were the inclusion and exclusion criteria. Age we have taken more than 18 years. Patient with COPD pneumonia needed admission. All those patients were taken. Those are non-diabetic and those HbA1c level was less than 7.5. Exclusion criteria: intubated patients having poorly controlled diabetes, newly diagnosed diabetes, those patients were not taken in this study, as well as end organ damage like nephropathy, retinopathy, those were also excluded, sorry. So what we have found in next 7 days, you see the insulin requirement after the admission in first 7 days was 132 units, which was more than twice value of mean insulin level, which they have required at home, which was 62 units. So like some patients were like taking insulin 4 units 3 times in a day at home. So we have observed, we have taken those values pre-COVID-19 period insulin levels in 7 days, and we have compared with the next 7 days. So that was even more than 2 times. You can see that range from 1.5 to 2.5 times from the baseline during the first and next subsequent 7 days. So severe group, severity of COVID we have also analyzed. So severe group had poor glycemic control requiring higher dose of insulin compared to the moderate and mild cases. So COVID-19 pneumonia significantly increases insulin resistance and insulin requirement during illness in fairly controlled diabetic patient. And this value I have told you, 1.5 to 2.5 times higher level of insulin doses were required to maintain the glycemic control. So there are various mechanisms, various hypotheses, but still we need more data about that, like elevated pancreatic enzymes, direct cytotoxic beta cell damage causing loss of function of pancreatitis, features of post-mortem analysis, and studies supporting insulin resistance for COVID-19 induced hyperglycemia have demonstrated that hyperinsulinemia and elevated C-peptide levels. What are the other mechanisms? Like we all know, connection between COVID-19 and insulin resistance is likely the angiotensin converting enzyme, which is abundantly found in pancreatic beta cells. So this enzyme serves as a receptor through which coronavirus like SARS-CoV attaches to the target cell. So blocking or inhibiting the ACE receptor leading to significant increase in angiotensin 2 levels and thus hyperactivity of renin-angiotensin-aldosterone system, resulting in elevated oxidative stress and reduced sensitivity to insulin. So now we'll discuss about a meta-analysis. Diabetes is most common, important cause for mortality in COVID-19 hospitalized patient. So this analysis was done in multiple countries, almost 3,700 retrieved articles, 87 studies were considered, including almost 35,000 patients and almost 6,000 deaths we have observed in this meta-analysis. Mean age for this meta-analysis is 60 years to 70 years. So diabetes mellitus was the best predictor for mortality rate in the all age and sex dependent manners, followed by COPD and malignancies. So you see the mortality rate in US, Europe and Asian countries are 25%, 20% and 13%. So meta-analysis was performed with the PRISMA, that is preferred reporting items for systemic reviews and meta-analysis. And this protocol of this study was published in website of University of York. So what are the predictors of mortality? You see among all the parameters, dyspnea, fatigue and myalgia, these are the 3 parameters along with the increased respiratory rate, which are the best predictor for mortality rate. Lab values, if you can see, reduced lymphocyte and platelet count, reduced eosinophil count, increased D-dimer level were the best filters. So mechanism we have discussed. So basically diabetes contracting COVID-19, actually its presence is closely related to worse outcomes because of modulation of immune response and ACE2 receptor expression of virus. And this mechanism we have discussed in previous slide. What are the other mechanisms? As we all know, in diabetes, our pulmonary dysfunction due to decreased lung volume is there, reduced pulmonary diffusion capacity is there. Diabetes causes impairment of ventilatory control, bronchomotor tone, and non-adrenergic innervation, as well as infection. So there is one coronado study, that is coronavirus SARS-CoV diabetes outcome study, which is the French study, multi-center study, which has reported that hyperglycemia at admission worsened the patient prognosis. So found with the SARS and Middle East respiratory virus syndrome. So you see the associated comorbidities. Arterial hypertension is the highest, most prevalent, causing mortality 40%. Diabetes is number 2. CVD and CKD are next, and then malignancy and COPD. So symptom-wise, if you can see, fatigue, dyspnea, and myalgia has high mortality rate among all the symptoms. Whereas fever, cough, we don't have any association. Nausea, vomiting, sore throat, anosmia, we don't have the significant data to say that these symptoms were associated with high mortality rate. Labs, you can see association of D-dimer and C-reactive protein. There is no association of data of mortality between IL-6 and TROP levels. No association between mortality rate with high blood white cell count and hemoglobin levels. Thank you.
Thank you all panelists for bringing out so many caveats of this particular menace called diabetes and its impact on the lung in a very big way. Let me appreciate the efforts that you all have taken and the kind of data that you have put in front of us. What I appreciate the most is a lot of the work that you have shown is not international, but actually this is some of the work, at least 50% of the papers that you have quoted were Indian, and that is a very good beginning that is happening in this country, because otherwise we would always say there is no data from India. And I think this is a welcome change. Of course, the Chinese are still dominant in the data that we have looked at, and they will be like that for another 10 years. But I think we are catching up in the terms of data. So that is a very simple and a warm welcome message. And let's start with the various, there are so many questions in my mind, and I'm wondering where to start. But I'll start with our specialist and ask her a question. What is the safest HbA1c value where we will say, okay, this is what is fantastic, and this is what gives me an idea that the lung infections are less likely? Of course, it's a very complicated and a loaded question, but I think we'll give her a try on this, definitely. Dr. Shailaja, please.
Yeah, that's a very interesting question. See, one is when we are looking at targets for diabetic control per se, we would stick with the 6.5 to 7 targets. But when we are actually looking at evidence to say at what point the incidence of, let's say, either TB, COVID, fungal pneumonia, and these sort of things go up, if the HbA1c is more than 9, there is a markedly increased risk of all of these things. So that is the point where we have solid evidence that incidence and prognosis is worse beyond 9.
Beyond 9.
So if someone comes at 7 to 9, get it down. More than 9 is where we'll be careful.
I think because that is what was reflected in Dr. Jayaraman's case that he showed, and that Mucor that he showed. And Dr. Jayaraman, you have any take on this? Anything different to say? Anything to add? There was I have a few questions for Dr. Jayaraman, though it is not purely related to diabetes, but this is a $1 million question which has been eating me forever. Is when I say chronic pulmonary aspergillosis, chronic necrotizing aspergillus pneumonia, or a frankly invasive aspergillus, what is the exact duration that the guidelines are recommending? Are there real clear guidelines in the first place? And what should be the duration in that kind of situation? And we'll come back to Dr. Shailaja on this also.
Yeah. Thank you for this wonderful question. Again, you said this is a $1 million question. The several papers clearly mentioned that, the acute pulmonary aspergillosis or acute invasive aspergillosis, the acute condition is maximum 6 to 8 weeks period. Anything beyond 6 to 8 weeks period, we call it as usually chronic. This definition correctly fit into the whatever the invasive and the chronic pulmonary aspergillosis or mucormycosis, whatever you say. So anything more than 8 weeks in general, so we call it as the chronic one. So less than 8 weeks, we call it as the acute one. This is general. So the others' opinion, please, other panelists' opinion also is well taken. Please.
Dr. Shailaja, you have any take on this? And we'll go to everybody else, I think, because this is interesting. Yeah. I always, very frankly, the semi-invasive, so-called semi-invasive versus invasive creates a little bit of difficulty for me. And I am unable to stop, particularly something which is working and maybe in a follow-up territory, the drug which is relatively inexpensive, for example, itraconazole, relatively inexpensive, because all the antifungals are otherwise horrendously expensive. So the duration becomes difficult, and then there are times when we are not able to really take a decision when to stop it. So Dr. Shailaja, can you start with, can we start with you? Because I'm sure you must be seeing a lot of these coexistent fungal infections. And you must be helping the doctors to treat their diabetes control side by side. And I would like everybody on the panel to talk about this. Dr. Shailaja, I think you are on a mute.
Dr. Samantha, ma'am?
Yeah, hi, sir. So I was actually slightly confused. So I wouldn't actually get your question. I think you're discussing about your duration of, so you went to say between chronic and acute, and of course duration of treatment. For us, from my side, the relevance would be, of course, to make sure that glycemic control is good.
Control is very good.
Yeah,
Yes.
throughout the duration of treatment, and to deal with the particular problems associated with particular medications that you might be using. So is it one of the azoles which can cause either your issues with liver? Some of the azoles are known to cause hyperglycemia as such, things like posaconazole. Some can affect the adrenal, cause adrenal insufficiency, hypokalemia, or if you're using amphotericin. So the two aspects for me would be to maintain blood sugar control and also look at possible issues associated with the drug you might be using long term.
Yes. Any other inputs on this? I have a sub question to this, but I think before that, Saurabh, you have any inputs on this? Dr. Suryakant, you have anything? Devi, any inputs on this?
There are a few studies which show that a longer duration of action in immunocompromised patients. So when if in a immunocompetent patient we get, say, a fungal infection, we may give it for extra 1 week. Like normally we give it for 2 to 3 weeks. But if the glycemia is high, and if we're able to control it fully, then it's fine. If not, we may give it for a further period.
I think so. I'm going to ask a sub question because Suryakant and I want them active. So Suryakant was the first talk on the diabetes, and I have a sub question to this on the TB related issues, because tuberculosis, controlled or uncontrolled. I mean, we assume that once you diagnose tuberculosis and diabetes together, you are very unlikely to have a person who's poorly controlled. Of course, that can still happen. Theoretically, it is possible. as Dr. Shailaja was pointing out, some of the drugs also may be making diabetes worse, like posaconazole, but we are not going to use those kind of drugs. The conventional first-line agents do not really tamper with the sugars in a very big way. Despite that, the conventional wisdom which has been taught to me and I have followed for a very long years is we typically stretch the duration of anti-tubercular therapy when I have a coexistent diabetes. Right, wrong, debatable. Where do you take the stand on this?
Usually, if it is a background of a relapse or uncontrolled, it's always better to extend the CP, the continuous phase, for another 2 months to be safer side rather than.
And also, I'll ask you probe on the intensive phase, and we'll go to everybody else and their opinions.
See, it depends, sir. If within 2 months of IP, if everything is good, the sugars are under control, and the X-ray shows much better, and ESR come down and clinically better, I'll just extend the CP. If the other way, then may extend the intensive phase for another 1 month. Depends upon the condition. It all depends where the patient is tolerating and the regimens were taking adequately based on the weights.
There was a little bit of a so I think you will probably play safe and go case by case. Is that right? That's
Yes.
what I'm hearing.
Yes.
Dr. Jayaraman and Dr. Saurabh.
Yes, sir.
Can you come in
Usually,
on?
yeah. Usually tuberculosis, the duration is short course chemotherapy is 6 months. So sometimes we may extend 9 months. In the case of extrapulmonary lymph node tuberculosis and others and all, we may extend up to 1 year. So during the intensive phase, usually 2 months we give. Depends upon the patient improvement and the sputum status and the other clinical scenarios. We may extend another 1 month. The participant will also extend another 1 month intensive phase, 4-drug regimen for first 3 months. Then we continue the in the continuation phase for another 3 drugs for 7 months. It depends upon the patient improvement and the clinical improvement. So we continue. So totally nowadays we are all giving the short course chemotherapy 9 months in the case of pulmonary tuberculosis. So 6 months to 9 months is our thing. So in the extrapulmonary we may extend 1 year also in a bone tuberculosis, cox spine and lymph node tuberculosis along that. This may take.
Yeah. I think I'll rather agree with you on this. And is there any other opinion from the house, Dr. Shailaja? You have anything?
Samantha.
Dr. Samantha, sorry. I'm sorry. That's why she was confused last time. Sorry.
Yeah. Other than, of course, you do treat patients on a case-by-case basis, but generally, practically most of the diabetics who end up with at least the more extensive forms of tuberculosis tend to be badly controlled, and their badly controlled diabetes would have been a big contributor. So they present with worse forms of disease, and also probably see that they have a higher risk of treatment failure, relapse, treatment resistance, and issues like that. So I think we practically see is that they end up having longer courses of treatment as compared to, let's say, otherwise someone with no comorbidities.
Samantha, ma'am, one question to you, ma'am. Are you giving ATT 6 months or 9 months or case basis you vary, madam, for diabetic and PT?
No, so I only treat the diabetes by colleagues like Dr. Vijay.
Right.
So what I see is, they tend to be poorly controlled, so they usually present with worse forms of disease. So practically.
So for all practical purposes, you'll end up giving a little more duration.
So they might end up requiring more because their disease is worse to begin with. And
Devi has raised her hand. Devi,
is higher.
Please come in.
I have a doubt. I personally like my TB patients if they have like a bit high HbA1c, say more than 9, and even if they are on oral medications, I am more comfortable if they are shifted to insulin and they are well controlled. What is your take on that, ma'am?
Oh, that's an interesting
point. End up requiring insulin, ma'am. So one is, of course, this your LFT may get deranged when you're giving ATT, and then they end up, of course, requiring insulin. We have to take them off oral drugs. The other is overall, we also prefer giving insulin because insulin is more of an anabolic hormone. It will increase their appetite, make them feel better. And even for control of their sugars, a lot of them would require insulin. So the vast majority go with insulin unless they're really well controlled. So they generally do better with insulin, at least during their intensive phase.
One more point addition to that, if
Yes.
the patient is on diabetic with polypharmacy, it makes miserable as severe gastritis and all that. So better is to control with insulin along with the ATT. Already ATT is already 4-5 drugs, so it's better to go for insulin rather than oral upperglycemics.
I completely agree with you.
Yeah. So I think there seems to be a consensus on this, that largely particularly in the intensive phase, when the drug load is very high, and if the patient has an extensive disease, you might start along with insulin, and then as things become better, you will tend to switch down to oral therapy as relevant whenever the success is already established. And I think the second component to it is, as she is very rightly pointed out, that most of these people who are otherwise poorly controlled may be having more extensive disease and therefore possibly a longer duration. Of course, this is not really, very frankly, WHO just doesn't talk about this. It leaves it to the doctors, and therefore the pulmonologists have to take a lead and say, okay, possibly a little longer duration is going to be relevant in individual patients. I'm not saying generalized guideline, but an individual patient, on patient-to-patient basis, you can definitely prescribe a little longer duration of therapy as well. Even the maintenance phase can be a little longer if it is relevant to that particular individual. Of course, somebody who had a pleural effusion, very mild, and everything is hunky-dory at the end of 6 months and the brilliant control of diabetes, we may stop at 6 months also. It's not a must to go on in every patient to 9 months, but by and large, because they have more extensive disease and because there are more poorly controlled scenarios, so a little longer IP and a little longer maintenance phase is, I think, what may be the best message that I can possibly.
So one point I want to make.
Yes, Saurabh, please.
So, sorry to interrupt you, sir.
Yes, please,
Actually,
don't go ahead.
I was telling the same thing, like our guidelines, guidelines we have, even NTP guidelines and even WHO guidelines, they only mention extension for like disseminated bone TB or CNS TB. They have not mentioned particularly that diabetic or any other comorbidities. It should be extended. So it should be our personal decision, case to case. We can decide whether
it is case to case. Guidelines are not at your. That's why I raised this question, because guidelines are very clear about 6 months and fairly rigid about it. Drug sensitive tuberculosis, minimum duration of 6 months. Even DRTB, it is not going beyond 9 months, depending on the longer or the shorter one. So whatever prescribed duration, they are fixed about it, and they are not changing it on the basis of presence of diabetes alone. So I take that point. I would try to stick to the guidelines as far as possible, but there are a number of individual scenarios where you will probably extend. I hope we all agree on that.
Yes.
And I think it happens in more than less often, because as Dr. Samantha very rightly pointed out, I've got it right finally. Sorry. As she has very rightly pointed out, because they're poorly controlled, they are very likely to have extensive forms of tuberculosis. And Saurabh, you sitting in Mumbai, I think you are sitting in the drug-resistant tuberculosis capital of this. So the next question I have for Dr. Samantha is, why is this scenario that this will probably go to all the panelists? Why such a large diabetes load in India? Why are we different, and what can be done about it? So we'll start with the expert, and then everybody else's opinion will take it.
So the genetic component of diabetes, of course, we cannot do much about. So there is a huge genetic component where we are predisposed to insulin resistance. We have smaller, our pancreas tends to be smaller with fewer beta cells. So we run out of beta cells also faster. And the things we can change in future, of course. So after genetic comes epigenetic. So overall, treating mothers in pregnancy, encouraging healthy lifestyles from the start would actually help prevent epigenetic changes which predispose to diabetes in the next generation. And for those of us, who are already adults here, it is, of course, we'll have to go with lifestyle changes and things like that. So a combination of genetics, epigenetics, and environmental factors probably has pushed India to the place where it is as the diabetes capital of the world.
Yeah, I think so. So from the panel, I mean, yeah, Saurabh, you can come in, please.
Yes, sir. So like in our country, like every 11th or 12th person is diabetic. And you come to Mumbai, every 4th or 5th person is diabetic. So basically, like ma'am said, that lifestyle and two
All
things
Mumbaikars are extra sweet, huh?
Hyderabad
So-
is extra sweet.
So, sir, as Dr. Samantha said, like I think two most important things is lack of physical activity. Definitely genetic predisposition is there. And second thing is diet, which is mostly carbohydrate rather than protein.
Yeah, I tend to agree. You know, carb-centric diet is one. And yes, I mean, I absolutely agree that people don't work in this country, particularly
Yes.
those who can afford to work. So it's like, you know, so I think there has been a little bit of a lack of focus that the food availability has kept on getting better. We are no more a poor country anymore. I mean, we call it ourselves developing country for getting advantages, but I would rather classify most of at least the city life is into more like a developed country. And but the lifestyles have gotten worse rather than getting better, particularly in the terms of diet and exercise both. Devi, you were going to say something?
Yes, sir, first of all, wonderful news. We have more than 1,200 logins. And
Oh, lovely, fantastic. Krishna has sent you that message. Oh, fantastic, terrific.
And sir,
So,
besides genetic and our walking, exercising, and carbohydrate centric food, as you rightly said, that our income has increased, and now we are more used to eating things which our body is not used to. Like our one generation up used to eat the local food, local fruits, and now we are more into burgers and pizzas and noodles and everything. And
A lot
our
of processed food. Processed food is one of the
body is
considered to
not
be one
used
of the risk factors. Yes.
uh,
Yes.
this is for the
Please come
for
in.
Samantha, Raghukanth. Yeah.
Yeah.
One of the factor other is stress.
I think there's something short-term memory loss for me today. So I'm acting like Gajni. Sorry. Okay, please go ahead.
Before competition, I may get another name or multi-name pharmacy, like multi names for me, Raghukant. So just joking. Just on to Samantha, like when as pointed correctly, like mostly genetic and food lack all this, but one more component which is lacking is the stress. Because this ultimately
Very good
impact
point.
in all the way. Indirectly influence the health, and which ultimately turned out into the low activity and increased weight and all. What your comment on this?
So there is evidence to show that no stress and this late nights, altered circadian rhythm, all these push up your cortisol levels, change your body structure, increase insulin resistance, and definitely it is associated with diabetes, hypertension, cardiac disease, and all these metabolic factors. And the other thing I would like to say is, even though urban life is developing fast, unfortunately, what we see in cities is it is easier for the poor people to eat unhealthy food. So healthy food has actually become expensive. So they're forced to sort of subsist on no high carb, oil, and sugar and stuff, which is actually, I think, cheaper. We are heading the way the US is headed, where actually poverty becomes a risk factor for obesity.
Yeah. I think, US probably has gone through and is there now coming down on that curve. But 50% of the US population is extremely super fit, and the remaining 50 is super unfit. So I think you see two extreme forms of it. One which is obese and absolutely immobile and having all kind of, and the other one is like those who are having a laptop on their backpack, wearing jogging shorts and going to the work with 1.5 hour jogging. So those kind of so people have all kind of adaptations and maladaptations to the changing lifestyle. So I think we probably are heading towards this disaster, and I think as a country we have to awake get early onto this, because we are otherwise going to have poorly controlled diabetes as one of the problems which will keep on haunting us one way or the other. Any other comments?
I fully agree that Samantha ma'am regarding the sleep and circadian rhythm. There are a lot of disturbance nowadays because of the stress and the night shift workers, junk food, and diet and exercise plays a major role in controlling the metabolic diseases apart from the congenital thing and all. There is sleep is a very important vital metabolic function. So if you don't get proper sleep and all, it may lead to a lot of metabolic consequences like diabetes, uncontrolled diabetes, hypertension. There are a lot of metabolic syndromes. Syndrome X, syndrome Z, and all. So the sleep is very important. Altered sleep, which leads to a lot of hormonal imbalances. Samantha ma'am clearly said that. I fully agree, ma'am. Thank you.
So while we are on Dr. Jayaraman, I think I am going to ask him a few questions which are little disturbing to me about the. So I mean, one of the things which, of course, this also goes to Saurabh because he's also talked about the COVID-related day. So that meta-analysis and Dr. Jayaraman's talk about the fungals. And we had an epidemic of mucor during the COVID. And during that, COVID, mucor, and diabetes becomes like a triple whammy, isn't it? And then we had huge amount of issues related to the amphotericin B availability in the first place. Posaconazole cost was one of the issues. So many of them had, of course, we are not discussing that right now, but so many of them had the maxillofacial and they eventually CNS. And some of my patients have really, were in a dilemma after about a year's therapy that whether they should really be continuing posaconazole anymore, because the neurologist said you should take it for one more year. They were pretty good. And we were not sure what's happening there. So the question is not related to posaconazole duration therapy or anything of that sort. My question is more related to diabetes. We were expecting, first of all, diabetics to be more sicker, higher mortality. And some of the studies that have been quoted have shown us that Devi studies related to diabetes show that, yes, hospitalized patients with diabetes show higher mortality and longer duration of stays. But in COVID, the unique scenario which I've seen is most of my COVID mucors have survived. I have lost very few. There were some, even the members of Legislative Assembly in Maharashtra who have lost their life. Not that people did not die, but there was a considerably less mortality. And I want to know what is the reason. The last I will come to Dr. Samantha, but I will start with Saurabh. What is your take on this? Why still very good outcomes despite a triple problem there? Unknown virus, absolutely altered immune process, poorly controlled diabetes, and mucor. Add on top of that. That means the initial starting point is indicating towards a very poor prognosis. When you have lung and mucor, you have 80% or 90% mortality because it's poorly controlled. But why in COVID we somehow had not so much mortality?
So, sir, we don't have actually consolidated data actually for this, but definitely your observation is bang on. I mean, right. What we have also seen here, when lung is involved, those cases we have seen very few cases when lung as well as upper respiratory is involved. In those cases, we had very mortality is high. And cases where lung is not that much involved, and upon that we had some comorbidities like diabetes and the fungal involvement, the mortality is actually not that much what we are thinking about. So that is my observation.
Because we were losing people like rats during the COVID pandemic, and maybe because our focus was higher, or maybe there was a lot of attempt to make amphotericin B available. Because I remember there was a time in Pune when there were 70 cases of mucor at one time in Pune city, and we were like hunting for ampho. So that was the state of affairs, and still many of them made a good recovery. Any other comments from anybody else? And we'll go to Dr. Samantha as final remark on this particular very contentious issue. I don't know the real answer there.
Yeah, mucormycosis, black fungus. We have seen a second wave of COVID. A lot of patients developed a black fungus. The etiology behind, one of the theory behind is the high dose of steroids. We are not following the recovery trial properly. Recovery trial is recommending only 8 milligram of 6 milligram of dexamethasone per day for 5 to 10 days only.
Yeah, and people were reporting it.
Right.
Yes.
Left and right, we give, sorry, but 125, 250. So we give a lot of doses in second wave to prevent fibrosis, to prevent the complications. That is the main culprit. Still, we don't know the exact etiology, why the hyperglycemia, why the mucormycosis, black mass happening in that field and all. So still a lot of queries about that. So I want Madam Samantha's comment on that.
Yeah, let's hear from her then. Yeah.
Yes, so one is of course that mucor tends to thrive in an atmosphere where there's high blood sugar, acidosis, ketosis. So really high blood sugars as well as diabetic ketoacidosis, maybe even mild. So all this is very common during COVID, because COVID also increased the insulin resistance. Of course, steroids were being used. So very high blood sugars, acidosis and ketosis, all this was occurring very frequently. So probably that played a part in the mucor. I think one thing that was good was that there was a high index of suspicion. So people were getting diagnosed fast. Somebody just says face pain, my nose feels stuffy, they were getting diagnosed. But before this, the few cases that I've seen, like in the pre-COVID era, the index of suspicion used to be low. By the time the patient is diagnosed with mucor, the eyes will literally be popping out, there'll be cerebral involvement. So beyond that, you can't go very far there. So probably the high index of suspicion early and effective treatment also could have given us good results. So that would be one thing.
Yeah, I think that is us possibly because we were so immensely focused on managing these patients extremely well and hard. Possibly that's why we were, because otherwise in the community, which is at ease right now, which is the story, we are seeing more viral pneumonia related deaths one way or the other. So I think that seems to be the story now as compared to what it was during the COVID time, because we lost hardly, I'm sorry to say 8 lakhs lives don't matter. They did matter. We lost 8 lakhs of our colleagues, and there was a person particularly in the second wave, everybody has lost one family member or the other in one remote way or the other. But at the same time, we still had a reasonable good outcome, not only in the COVID, but in severe COVID pneumonia, with diabetes, and even in mucor. In all those ranges, we were doing pretty all right, despite the fact that we are a resource limited country, particularly when it comes to a little away from the cities, the resources are severely limited, and still our mortality rates are not all that bad actually.
So one question I want to ask
yes,
Dr. Samantha.
Yes, please go ahead.
We had a lot of cases where the sugars were normal and no extra steroids were given. Even we have seen so many fungus coming from the distant part of Maharashtra to Mumbai. And we have checked the details. There were no sugars were normal. Even the COVID was mild to moderate. It was not severe COVID. And HbA1c value is not that high, 6.57. And despite, do you think there is some kind of barrier loss or patient become more vulnerable after COVID infection to catch the fungal infection rather than thinking about extra steroids and glucose levels?
So one is, of course, the immunocompromise as part of diabetes would have played a part. And these fungi are, of course, they're present in the air. So its source is not a thing. So some issue with barrier could also be there. But I don't think anything like that has actually been proven. But of course, that is a very sort of possible picture.
I think one more point I can add here is, of course, they were talking about poorly delivered oxygen is one of the causes, because that was delivering mucor else to the systems. But I think this is to do with the lung microbiome in total, and we have to look at that. And I think some people have been already harboring the mucorales one way or the other. And I came across Dr. Agarwal's lecture recently in one of the meetings we had, and he's an expert on lung microbiome. And one question I asked him about that, and I keep asking this, is that once in a while when we just do a bronchoscopy, and we do it for some infection, tuberculosis, blah, 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 whatever we are suspecting, and or even for hypersensitivity pneumonitis. And the next day, the microbiologist calls me and says, are you suspecting mucor? I am seeing mucor there. So the lung microbiome may be the answer to this very contentious and difficult question. Because why? As you very rightly said, some people were overusing steroids. Some people were never overusing steroids. They were just right dose. Everything was perfect, and still they got a mucor. And that would be because of the virus-induced regulation of the immune system, but somewhere the mucor had to be present in order to activate itself. And therefore, I think the issue of lung microbiome, of course, we right now will not be able to monitor everybody on lung microbiome business. This is for future, but I think this might be the answer, that they were already pre-colonized or, harboring it. Aspergillus is the same story. Candida is the same story. We all harbor it and it activates at a particular time when the immunity goes down. So I think that must be the answer. That is what comes to my mind. You have anything else to say, please?
Sir, I can see one question also regarding false positive beta D glucan and galactomannan.
In fact, I was coming to that. In fact, yes, absolutely. Yeah.
So we are discussing fungus, so we can.
In fact, very, very important, because this was my next question to Dr. Jayaraman, sir, about galactomannan, about beta D glucan, and about in general, for how valuable are these very expensive tools in making a conclusive diagnosis of who's the one? I mean, can you read that person, Dr. Tony Luke Kerala? Some guidelines. No,
Madhur Joshi, Rajasthan.
Dr. Madhur Joshi.
Madhur, can you read the question? I'm not able
Dr. Madhur Joshi from Rajasthan, Jaipur is asking causes of false positive beta D glucan and galactomannan.
Perfect. I think it's a very valid question. So our expert is Dr. Jayaraman right now on this. So we'll take it to him first and then everybody else.
Yes, sir. This is a biomarker for diagnosis of Aspergillus, that is beta D glucan and as well as the galactomannan. This is not a gold standard test, like we are doing the ADA level in a pleural fluid and acidic fluid. Likewise, there is a cutoff values here. This is not a gold standard. Gold standard tool for diagnosis of Aspergillus and other fungal infections, mainly the culture of the specimen as well as the histopathology. In the case of mucormycosis, tissue is the issue. Tissue diagnosis and the liquid biopsy material, you have to culture. That is a gold standard. These are the biomarkers. Sometimes it may show false positive, false negative. So based on this, the bronchial was galactomannan and beta glucan have higher value than the serum galactomannan and all. These are non-specific biomarker. This is not a gold standard. This is, you can call it as a bronze or silver standard to take it as a false negative. So based on the clinical and the underlying conditions and the bronchial wash or bronchial lavage culture for the fungus as well as the histopathology specimen, which is the gold standard. So always, this is a teamwork, multidisciplinary. We support all the evidences. So culture positive, histopathology is a positive, showing a separate hyphae in the staining pattern. Plus the galactomannan is a high and the beta D glucan is high. This is more in favor of these high fungal infections. We can take it as a granted and start the medication. Usually, we involve the multidisciplinary team approach using we are replacing the microbiologist, diabetologist, infectious consultant, and the pulmonologist. We sit together and take the decision about whether it's a positive, false positive, or some other test to be done, or additional test to be needed for the supporting the diagnosis and treatment. So this way we usually proceed. This is one of the biomarkers. That's all.
Any other viewpoints on this? I mean,
just one thing I want to mention, that about the piperacillin tazobactam preparation once we give. So we see falsely high levels of galactomannan in those patients if it is given recently. And secondly, the patient is given albumin or immunoglobulin. In those patients, we can see falsely positive beta D glucan levels also.
Perfect. I think these are very, very valid points. So these are work for the doctors to keep in mind. Surikan, you were about to say something?
Raghukanth.
So sorry. My short-term memory loss still continues. Sorry.
That's right, sir.
I'm still not reading it. Sorry.
Yeah. What Jayaraman sir says is correct. It is all cumulative points. Like overall, we'll see many of them chronic lung disease or cavity also give a false positive when you take. But so ultimately, you need clinical judgment, CT, and then we need to take points to consider whether really required a antifungal therapy or not.
Yeah, I think, so we can't just take one single, I think the message is very clear from and I think Dr. Samantha will also agree on this, that it should not be one single marker, a biomarker as a final decision maker, but it's a clinical diagnosis which is supported by multiple concomitant corroborative evidences. And of course, I mean, we would love to have a biopsy, but biopsy is not possible in every patient, in every situation where you have documented invasion. There was a school of thought once upon a time that invasive aspergillosis is only diagnosed by a biopsy documentation. Today, gradually people are saying at least do a BAL because the local tissue matters. And then if I have a spillover into the blood, it is even better because it tells us, yes, there is a angio invasion. So that's so combine these factors, that a clinical syndrome exists, that a right radiological pattern exists, that there is a local documentation from the BAL or from whatever source that you are using, or a mini BAL or whatever that is, and which is showing presence of some form of fungus, and then there is angio invasion in the terms of beta galactomannan, then I think I will take that as a composite rather than taking a single parameter as the final decision maker. Plus, what Dr. Saurabh put you as, piperacillin tazobactam, be careful, because if you are using that, and a lot of our severe caps are being treated with that as one of the first line antibiotics. So I think be careful there. And the other drug that you mentioned was albumin for the beta glucan. So I think these are excellent take home points. Absolutely. I think while we are on Saurabh, one of the issues which comes from his presentations was insulin resistance. And we saw that the Indian data, because insulin resistance going up as was one of the issues. Any inputs from Samantha on this? I mean, is it just that, yes, genetically we are like that, or is what something else happening with COVID? Because there was the article which he presented which showed clear rise in the insulin resistance. Though it was not a huge number, but I think 75 odd patients, but it was well documented.
Yes.
Yeah.
So no, there were a lot of articles which actually discussed insulin resistance in COVID. So let's say we are comparing a patient with some other reason for hospital admission or some other community acquired pneumonia versus somebody with COVID. So the patient with COVID required actually 2 to 3 times the amount of insulin as the other person, and as much insulin as their baseline insulin, even without steroids. So this was attributed mostly to the strength of the inflammatory response, which increased insulin resistance, and also probably a direct cytopathic effect on the beta cells of the COVID virus. So, and practically another thing we had to keep in mind was, as the inflammatory response was coming down and as the patient got better, we actually had to watch out for hypoglycemia also. So even if the patient is being treated on OP basis, let's say I double or triple his insulin dose, and then as I follow him up, I would have to follow him up closely to see that he doesn't go into hypoglycemia as he gets better, as the inflammation is coming down.
I think Devi presented a very yeah, thank you. As you know, I'm going back to Devi, and this is about her presentation. And Dr. Samantha, you have to answer this again difficult and contentious question. That poorly controlled as well as well-controlled diabetics were equally at susceptibility to COVID. They did not really attract more COVID. Was that the message in one of your papers?
Yes, sir. So,
how do we explain that? First you can start, and Dr. Samantha can take over.
The risk of infection was similar in both, but the severity was more in poorly controlled.
Yeah, the severity was worse and the prognosis was worse. So diabetes and obesity both. So the risk of getting disease was not different in a lot of both national and international papers, but they were predisposed to more ICU admissions and worse prognosis was.
Correct. So it's it all about just the idea that they were very well isolated and therefore they did not contract the infection, or there was something else? Because let me quote it from my own, charity begins at home. So I was the first doctor in Pune to get COVID pneumonia. I'm extremely mild diabetes. My wife is a relatively not so well controlled diabetes. Both of us are diabetics. And therefore, possibly I have been made the moderator here because we are, and so many people in my family have diabetes. But I was the one who got it. I was extremely mild diabetes. I mean, just my highest postprandial is 190 or something of that sort. And my HbA1c is never above 6.5, max to max 6.7 once in a while, but never more than that. But I was the first one to get it, actually. And my wife, who's also working in microbiology, was reporting 3,000 cases in a day and was very actively involved with the COVID and a poorly controlled diabetes relatively. She never got it. Or she got it, her antibodies became positive one fine day and she was protected. And she, of course, was lucky to get the vaccine early. So, so can we explain this paradox? And it was brought out in one of the papers. So, that's why I picked on to that point. So, Dr. Samantha, do you have an answer to this?
As to why they're not at higher risk of contracting the disease versus
Well, yeah, why not contact? Of course, we understand that a poorly controlled diabetes will have a worse outcome and a more mortality. That is understood. That is logical and it is expected and that is documented also time and again. But actually the risk of acquiring infection, is there something to do with the innate immunity? I mean, what protects some people more than others? And I'm not jealous of my wife. Huh? Please don't take it that way.
In my opinion, it's not about the glycemic control. It's an inherent immunity, I feel.
Yeah, I think there's that's something, because yes, you find some people getting every virus which goes around and some people just not getting anything at all. So possibly that is one thing. I mean, I really don't have a great answer to
polymorphisms in your AC receptor and things like that.
Yeah, I think I was coming to that because that was my next question about the AC receptors. And Dr. Saurabh presented that material.
Yes.
So can you elaborate a little on this AC business, and Dr. Samantha can eventually talk on that?
So AC inhibitors, as we have discussed, as we have seen initial mechanism when COVID has come. So AC receptors are there on the cells and definitely on beta cells and many other cells. So virus entry point is actually that receptor. When virus attaches to that cell and goes inside, then people were talking about ACE inhibitors, but definitely they were not going to help, and there is no data and no evidence is that they are going to help in those cases, definitely. So this is the entry point of the cell where the COVID virus enters. So that is about ACE inhibitors when we talk about the mechanism of how virus enters inside the cell. And what insulin does, like Dr. Samantha will elaborate it probably, that it attenuates that receptor response, I guess, so that it checks also entry of virus inside the cell. So like that, in few articles I have read that rather than putting the patient on GL1 agonist and DPP4 antagonist like sitagliptin and semaglutide, better to put on insulin when people have contracting COVID. So if some diabetic patient has got COVID, so better to give insulin rather than giving the oral medication. Am I right, Dr. Samantha?
So insulin is given mainly because the sugars are going to be higher and also because insulin has anti-inflammatory properties. As far as this receptor activity is concerned, the drug that was actually thought to exert a bearing was this DPP4 class of drugs, sitagliptin and that group. So they may have had some bearing in decreasing the risk of infection, but no solid evidence. So in the community, if somebody was a mild diabetic or had, mild COVID managed at home, they could be given DPP4 inhibitors, preferably, let's say, in preference to SGLT2 or GLP1 analogs or sulfonylureas or things like that. So the positive association was with DPP4 inhibitors.
So DPP4 receptor, actually DPP4 is related with MERS rather than COVID more. So that is what data I have found. So DPP is more related with MERS, where ACE receptor is related with COVID.
Yeah, but none of the antidiabetic drugs per se act on the ACE receptor. This DPP4 inhibitors could decrease the inflammatory response and risk of contracting COVID, not by acting on the ACE receptor though.
Okay.
One more question which is, in the back of my mind is, do statins make it a little worse for some patients? Because that seems to be the story that people who are on statins get worse infections when they get it. Of course, we are giving statins for a different reason altogether. So, of course, not related to diabetes completely. We are using them for reducing the cholesterol and the other things, so naturally. But is there anything in anybody's mind on this? I mean, it's an open forum question. I mean, have we seen data or experience of any clinical experience in this regard?
So in fact, I had read a very good paper. I don't remember the authors and all. They said that 80 mg atorvastatin should be given after recovering from COVID, like after
Okay.
the intensive phase is over,
Correct.
after you discharge so that
So statins were welcome in that the COVID kind of scenario. No, I'm talking in the general diabetes kind of scenario. So long-term use, because many of these are coexistent, altered TGs and altered cholesterol. So are we good? Are we do we have to be cautious there? Like what we were talking about ACE inhibitors and the DPP4 inhibitors.
So just to add to your question, sir, like I have heard in some diabetic conference that they have a higher incidence of new diabetes in patients who are on rosuvastatin.
Yeah.
The person who are taking rosuvastatin, they are getting early diabetes. I mean, I want Dr. Samantha's take on that.
Yeah. I think that will be interesting.
Yes, so one is definitely even lipid management is individualized for a lot of our diabetics. So we don't use, let's say, target of LDL of 70 or 100 as a blanket target. So we'll first have to calculate their 10-year risk of having a cardiac event. And if that risk is, let's say, more than 7 to 10%, then target values of less than 100. So a lot of people can directly use the ADA guidelines, which say 40 mg, 80 mg for atorvastatin, things like that. But most Indian guidelines don't actually use that dose of statin. So we stick to moderate dose of statins. The highest you go is generally that would be 20 mg of rosuvastatin or 40 mg of atorvastatin. And this also is usually required only for people with established cardiovascular or heart disease. So much lower dose is sufficient for most diabetics to maintain that target of less than 100. So the other thing is, of course, we would not really be giving higher dose of statin when they're, let's say, having an acute pneumonia and in hospital for that. So after recovery, probably we would target either lower or moderate dose of statin based on their cardiac risk. And this association of both all statins, actually, not just rosuvastatin, and also fenofibrates, which are widely used for triglycerides.
Correct.
So increased triglycerides can just be a manifestation of, let's say, increased blood sugar or insulin resistance also. So fenofibrate is actually very widely used in the community here. So both of those are associated with a small increased risk of diabetes. The risk is pretty small. But then again, so even if the risk is small, we should always calculate, let's say, a person's cardiac risk and use, rather than, let's say, then saying a person is diabetic, so blanket they'll have to be on statins. So that would not be the treatment approach now.
I think excellent points. I think there's a lot of learning happening here. And we have, of course, I mean, this is the beauty of, having a diabetologist expert here on the panel, that we generally are almost blind to this whole idea of, we don't think beyond lung. And I think similarly, you don't think beyond diabetes. So it happens. And unless we have a crosstalk, it doesn't really, these things don't come to our attention, that some things which we may be doing right or wrong can be either right things can be announced and wrong things can be sort of changed over to better practices. So I think we are nearly at the end of our talk. So I want each of you to give a minute of yeah, please. If there is any question, please let us take
We
that
have
first.
few audience questions actually. So
let's take them. Let's take them.
Can address that.
I'm somehow not seeing them in my mailbox. So can you read them?
Yeah, sure.
Yeah.
Dr. Raman Kumar from Tamil Nadu is asking, what is the most common pulmonary infection in diabetes? So, sir, I would like to take that question because I talked about diabetes and pneumonia. So, if we are talking about bacterial organisms, specific organism is not specific for diabetic or non-diabetic population, but a few studies have shown that streptococcal pneumonia is higher in diabetic patients, and Pseudomonas, Klebsiella, etc. Are similar in both diabetes and non-diabetic. However, opportunistic infections can be more in diabetes. So if you are asking about a specific organism, it is nothing like that. Diabetics can contract any.
Perfect. I think now I'm able to read the chat box. Dr. Sunil Arora from Punjab has asked about the management of ABPA in diabetics. And this is an interesting question. Dr. Jayaraman, can you take that? Because we talked on fungals.
Yes, sir. ABPA. See, this is an immunological reaction to the Aspergillus fumigatus. This is an allergic inflammation of the airways, which leads to all the symptomatologies that leads to the bronchiectasis and inflammatory airway diseases, which causes cough and wheezing issues. So most commonly we see in ABPA due to the uncontrolled, poorly controlled asthma. So ABPA management mainly to start with the steroid is the drug of choice. So we have to start the low dose steroids. So 0.5 milligram per kg body weight. So we can start the 20 milligram per kg body weight is fine. If you are diabetic patients, meticulously monitor the diabetic status, and if possible, you have to give the insulin under the diabetologist consultations. So the ABPA treatment, we have to finish it with starting with 20 milligram per 20 mg per day, and slowly you can continue for 6 to 9 months, 1 year, and see any recurrences and all. If the patient is not able to control with the steroid, we have to add the other antifungal agents like itraconazole or voriconazole. So seeing the clinical and the radiological pattern, if there is no improvement, we have to add the thing. Third drug in ABPA, that is in diabetic individual, we have to add the biologicals. This is the off-label drug only for ABPA, but these two molecules are very important. ABPA drug of choice is the steroids. So oral steroid, prednisolone, we have to start with, and meticulously monitor the other thing. If no improvement, we have to add the other antifungal agents, itraconazole. So this is the way we manage the ABPA, allergic bronchopulmonary aspergillosis.
Sir, I think
if I want to really raise a controversy here, I am a very good fan of deflazacort. It's a dissociated steroid, and I use that very often. I almost use it exclusively. I rarely use methylprednisolone in the hospital settings, but my OPD settings I tend to use, particularly when it comes to a long-term maintenance therapy. I somehow like it. I don't have great data to support it, but at the same time, this could be to your rescue when you are in a tricky situation, and we can ask Dr. Samantha also on that, and various. Devi, you were saying something. Please go ahead.
Sorry, Mr. I was just saying that I think he is trying to ask what dose of steroid will we give in ABPA with diabetes? Like if a say cellular NSIP patient comes to me with high HbA1c of 12 or 13, I am also skeptical about giving high doses of steroids. So do we decrease our dose of steroids in diabetic patients or not?
Yeah, I think, let me add one more point to this. This is not totally relevant to the today's talk, but as such, but very often we come across say hypersensitivity pneumonia and hypersensitivity pneumonia needing steroids. And one of the difficult questions I have to answer in my mind is this patient eventually going to develop an important infection or not somewhere down the line? And again, the issue of lung microbiome comes here. So it's been my policy whenever needed, I would do a BAL, I would do a transbronchial biopsy if it is relevant. And when we are sending the samples, we send it for everything, which includes the fungal, which includes the tuberculosis, it includes the gene expert, it includes an apiculture also as a standard of care, though I don't think any guidelines supports this, but it is a good safety valve kind of a mechanism when you are particularly going to put that person on an immunosuppression for say good next 2 years or at least 1.5 years. If it is a short duration for 5-10 days, I don't have to do that and that kind of documentation. But a longer duration, it might be, of course, the indication has to be there. I have to have a doubt about my diagnosis. It should not be a garden variety of hypersensitivity where the person is sitting with 300 pigeons and it is clearly a pigeon-related exposure. So then I don't have to document it. That is okay. But when I have a doubt about the etiology, I have a doubt about the fibrosis, I have a doubt about the presence of inflammation, sometimes a HP, UIP kind of overlap, I would go that little extra mile and try and get at least BAL, preferably a transbronchial lung biopsy whenever it is relevant, and then put the patient onto a long-term steroids. At the same time, documenting the absence of infection in a big way. I'm not saying it is really medico-legally safe or important, but it gives you a little more peace of mind, very frankly, and no guidelines support it, very frankly. So this is my opinion. Take it. It is not, the CCI disclaimer is already there. It is only my opinion. Okay. Saurabh, please come in.
Sir, just one question actually I wanted to ask to Dr. Samantha about the steroid. Like you have mentioned deflazacort. So we have prednisolone, we have deflazacort, we have methylprednisolone, we have dexamethasone. So any hyperglycemia, if I'm talking about, and I'm giving comparable doses like 5 milligram of prednisolone with 6 milligram of deflazacort. So what is the hyperglycemia we see the mechanism wise or whatever is more with the certain steroid, or it is equal for all the glucocorticoid and everything?
If you're giving equivalent doses, actually, it wouldn't matter. The hyperglycemia would be similar, but the pattern of hypoglycemia, at how many hours post-admission your sugars are, administration your sugars are going up, will be different, because the duration of action of all these steroids is sort of different. And another practical application of that would be, let's say you're using a particular steroid like Dexa, which acts slowly over 12 to 24 hours. I can use it with an insulin which sort of has a similar time profile of action, let's say Glargine or something like that.
Okay.
Or I can use short-acting insulin with hydrocortisone because they act quickly.
Okay.
So, otherwise, overall, if it's an equivalent dose, it's the same.
I think that's a very important.
Is actually good in, it is sort of a little more protective of bone as compared to the other steroids. That's the only advantage.
Okay.
Yeah, so long-term
Very valid
more sensitive. I think Naeem Dar has asked that question, and I think, while we are on steroids, let us take that question. Asthma, COPD, ILD, IPF, all exacerbations need steroid. It's a very, very, very valid point. So how do you deal with them and diabetes and their medication dose for DM? So part of that answer, I think she has already given. Can elaborate on that, and any other thoughts on this?
Yeah, any exacerbation of ILD or COPD or asthma, definitely we have to give the systemic steroids. There is no doubt, along with other supportive medications like nebulized medicines plus other medications. So there is no doubt, but definitely we have to use the steroid in the case of exacerbation. So COPD exacerbation, we call it as a lung attack. Definitely we have to give the steroid. It's one of the important drug. So at the same time, we get the diabetologist opinion regarding the diabetic status, whether to give insulin, how much dose and all. Routinely, we involve the multidisciplinary team with the diabetologist. We'll go ahead with the proper insulin dosage and all. Yeah, this is my opinion.
Yeah, I also think that you don't decrease the dosage of the steroid needed to treat the disease. You better increase the anti-glycemic medications.
Exactly. Correct.
That's right. That's right. The appropriate dose, and as Achi very rightly pointed out, inherent steroids will have inherent duration of action. So accordingly, that whatever dose of insulin that you're using, you might be using Glargine for a long-acting kind of a situation. That kind of adjustment has to be made accordingly. Another very interesting and bit provocative question from Dr. Tridip Chatterjee. He is expert in asking difficult questions. So that is from Maharashtra. Hi, Tridip. Mumbai, he is another Mumbaikar. He is a diabetic patient with non-resolving pneumonia, with or without cavity. After you do a BAL, you will send AFB cultures, routine cultures, fungal cultures, galactomannan, or whatever that is, and fungal smears. What else? Is sending biofire pneumonia panel is of any use over those instead of cultures? What is the opinion? I'll first give. I think Dr. Raghukanth. Next time I'm not going to go wrong.
Yeah, so this is a good question. Actually, it's a diabetic with non-resolving. So obviously, it's because this procedure, whatever you do, BAL, we can't repeat like a blood test, like daily basis. So when you are sending, especially when dealing with non-resolving diabetic uncontrolled, it's better to send biofire pneumonia panel to make sure early change in the treatment antibiotic. But routine use may not be required. Only in case of its acute or atypical presentation, you may consider it. But routine culture, routine AAB and all culture, AAB stain, gene expert can be considered based on the CT pattern. But usually, if it is non-resolving, please consider as a biofire pneumonia as a first entity when you are dealing with both combination.
I fully agree, Dr. Raghukanth's statement that biofire, we have to use it effectively in a case of complicated cases, non-resolving diabetic underlying conditions. We do not know what organism we are dealing with, the virus, fungus, or atypical organisms. Better you send the biofire assay, the case to basis, once again. But majoritarily in our center, we send any pneumonia non-resolving cases with comorbid conditions, respiratory failure and all. Definitely we do the biofire and start empirical antibiotic, all the medications, and de-escalate appropriately once you get the report. I fully agree, Dr. Raghukanth's statement. Thank you.
I think you have to also weigh the pros and cons of sending a biofire, because biofire is for the early and accurate pickup.
Yes.
So early is more important rather than accurate, because after 2 days in an automated culture system, the final result is accurate in any case. So biofire, the real advantage is a bad cap or a bad FAP when you need the diagnosis quickly within hours. And that's the beauty of biofire, because within 2 hours you have a biofire result available in many centers, and that can change your particularly resistant pattern. Say a drug is resistant Klebsiella, or Devi showed something about MRSA, because we don't think MRSA very practically very often. We see a lot of gram-negative rat-related pneumonias. So I think picking that early is going to be the real advantage. So if you think that the infection that you're dealing with is unusual or it is fulminant, then I would use biofire. I'm not going to use it in every case where I do a bronchoscopy, because that way we'll end up spending nearly doubling the cost of every bronchoscopy. Because
yes.
17 or 18,000 is the cost for a biofire. So though it's an excellent tool, I wouldn't use it everywhere. I would use it in right situations, and it should add, more importantly, I have to also deal with false certain whether the DNA signatures may be false. So again, the clinical interpretation of a DNA signature is in play. So we can't be just taking it at the face value. Nothing grows in culture after 2 days, but you have a drug-resistant Klebsiella. That was a tracheobronchitis and a colonized drug-resistant Klebsiella. It may be important to prevent it from the infection point of view, but it is not life-threatening. So I think we have to take that with a pinch of salt. So biofire, great tool for early, accurate, rapid diagnosis, but not a great tool for every single case kind of a scenario use. And of course, if you are sending a biofire, remember, please don't take it from a nasopharyngeal swab. It has to be from the BAL. If you do a BAL and send it, then only the pneumonia panel becomes relevant, because many people do that. Some of my residents have done that. Biofire based on nasopharyngeal swab, sir, gaya bhi. And I said, no, I wanted the sputum at least, induced sputum. So I think that is another message, very important.
And the cost is more than
Yes.
professional fees, sir.
Yes.
Yeah, absolutely. Dr. Praveen Tavre from Maharashtra, Mumbai is asking, how do you adjust the doses when you treat aspergillus with tuberculosis, itraconazole or voriconazole with ATT and with tuberculosis?
Yeah, the correct choice for aspergillosis is itraconazole. Alternatively, we can give voriconazole also. In the case of tuberculosis, there is no major drug interactions. You can continue the ATT as usual, like the normal standard regimen dosages, and you monitor any adverse reactions of the drug which causes any hepatotoxicity or other eventual complications. We have to clearly observe the patients, and periodically adjust the dose. There is no major drug interactions as well as any potency of drug at all. It's same only. So we can continue itraconazole oral drug. The patient is not able to tolerate, if the disease is very diffuse, we can start the voriconazole. This is the way we proceed with the consultation. We usually get a consultation from the ID specialist for these kind of slightly complicated cases like the aspergillus TB and other infections.
I think only I'll just add one part. Sorry, somebody's saying?
No, sir, you can proceed.
So what I thought was, I think the most critical part of ITRA versus voriconazole, the voriconazole has an excellent bioavailability, great absorption. Itraconazole, unpredictable in its absorption. But in a control scenario, either of the two are reasonably good options. the duration you have to adjust accordingly. And for a typical invasive, as you pointed out, it will be a few months initially. And in certain situations, like in chronic pulmonary aspergillosis, you may have to do a little longer business on continuing the antifungals. And somehow we don't have an exact endpoint defined for chronic pulmonary aspergillosis or semi-invasive aspergillosis. There, the decision is more clinical than guideline defined. Very clear guidelines are not existent. Another, I think this is in continuation with the question that Dr. Praveen asked about ITRA or voriconazole. Dr. Tridip Chatterjee again asked one more difficult questions. All other antifungals interact with the secondary AKT drugs like amphotericin or isavuconazole.
So actually,
Yes.
interaction between azoles and say rifampicin and secondary anti-TB drugs, and so there are many studies and many questions asking if we should give rifampicin, if we should see the levels of that. So what I found is that you can extend the duration for that, and if possible we can use amphotericin B in those cases, because coexistent fungal and TB is not something we see every day.
Yeah.
So bedaquiline.
Yeah.
Yes, sir. So bedaquiline and delaminate, we know all the azos they all can cause QT prolongation. So they are not good to give with the like MDR drugs, specifically the atraconazole and voriconazole. So we have to see, like Dr. Devi is saying, alternative for that. We need some ID specialist for that, like which should be given. I mean, if we are giving MDR drugs, and along with that, we want to give some antifungal in specific condition.
Yeah, this kind of situation, definitely we involve the ID specialist along with our regular, this thing and all. So we used to have the multidisciplinary discussion and take a decision which drug to be given, and in this combination, ATT plus the antifungal, amphotericin good or voriconazole. So we have to choose accordingly with the multidisciplinary team reports. Yeah, we'll follow.
I think, if I'm not wrong, we have more or less come to the end of these questions. We have covered almost everything from the end. So I think I'll request each of you, starting from the youngest to the oldest. I am assuming that I'm the oldest, so I'll have that. So we can start with Saurabh, probably the youngest one, if he looks the youngest. So your final comments on this. You have concluding remarks, and then we'll go to the next one, which will be.
So like we have seen all the pulmonary infections.
Sorry, Raghukanth. I got it right. Sorry.
So diabetes, definitely we see a lot of connection with our pulmonary infections. Everything, I mean, COVID, viral, fungal. So like Dr. Raghukanth has made, stress is very important factor. Like I have friends like physicians who are telling that HbA1c level is only high because of stress. They don't have, some patients don't have any risk factors other than that. So stress is very important. So it should be controlled, and so that we can very well control diabetes, and likewise we can control pulmonary infections.
So over to Dr. Raghukanth.
Yeah. Sir, steroids are major role in pulmonology, but many of them fear to use it when it's really required because of the sugars, or may long-term impact on the getting infection. But it's all clinical scenario where we need to see which is the best way to, ultimately we need to reduce the exacerbation. So it's a case basis. So better to control both exacerbation and the sugar diabetes.
Absolutely. I'll go over to Dr. Samantha. I'm going age-wise, but you can come in the final and give your final remarks as the expert. So, Dr. Samantha.
So yes, as a corollary to what Dr. Raghukanth said, I fully agree. So one is, of course, we should not be scared of steroids and treat the patient with the appropriate dose for whatever problem the patient has. And the other side of the coin is that they should also not be afraid of insulin. So that fear also needs to be taken away, which we will take care of.
Absolutely. Yes. I think that has been happening, isn't it? So
Yes,
I think the insulin
the fear should
resistance
not be there.
in the terms of the patient's mind is definitely going away, though Indians are insulin
Yes,
resistant
yes.
as a genome physically.
Yeah.
But I think that is no more the fear, particularly when they have
Yeah, it
gone
depends on
these
our
training
approach.
episodes, they definitely go on to it. And they hang on to it also. Dr. Jayaraman, sir?
Yes, sir. So my take message from this talk is early diagnosis is very, very important. We are all diabetes capital in the world. So prevention is better than cure. Pneumonia is the second leading cause of death in the world next to heart attack. So we have to give all the preventive strategies we have to follow, like diet, exercise for the diabetic control and meticulous control of diabetes status. And the vaccinations plays a major role. And the early diagnosis and identifications and involve the multidisciplinary team. So don't hesitate to approach the diabetologist or the ID specialist to get opinion, any dilemmas. So this way we can diagnose early and treat early adequately to prevent unnecessary morbidity and mortality. So this is my take message. Thank you, sir.
Excellent. So I'll just wind up, summarize all that you great people have said. Very excellent panel. We had a great interaction. I think we have exceeded the time. We are well beyond 9:45. That was the time given to us.
Devi, ma'am, conclusion, take a message, Devi.
Yes, sir.
Devi,
Everything has already been said, but I would ask all the viewers to have to befriend a good endocrinologist, so that when you need to treat the diabetes along with your chest disease, you will not be afraid to use some specific drugs, or you don't need to be afraid of the complications. That is very important.
Absolutely. I think very well said, Devi, that multidisciplinary approach is very important here. People have to hold hands, people have to interact with each other and talk to on regular basis. Just as we say, you have to go to the pathologist, you have to go to the radiologist, then MDD in interstitial lung diseases. Similarly, in infections, particularly for the diabetes capital of this world today, India, inherently we are like that. Our lifestyles are getting more and more westernized. We are in an explosion of diabetes, and therefore diabetes related infections are going to be there to haunt us for a very, very long time. And next few decades, we will be definitely encountering more and more such scenarios. So co-managing these infections and co-managing the diabetes along with the diabetologists and the endocrine experts, plus having some inputs in select situations from the ID experts also. So it's not going to be just pulmonology, it will be ID, pulmonology and endocrinology cohort, which will come together and manage this meanness. And of course, the most important bottom line, I hope it changes a day before yesterday, is the diet and exercise paradigms, which are very relevant for diabetes control. Very, very poorly taken messages on this. Well, I mean, I had a frank diabetes at the age of 37, and today I'm a pre-diabetic. And that is because I changed my lifestyle completely. And good 23 years, I remained a pre-diabetic. Now I'm borderline diabetic, you can say. So I think, well, I still keep catching the infections. That remains the issue, which is unsolved. And I hope one day all you good people find answers for why am I so susceptible to infections. That is a different story altogether. But I think the simple take-home messages are in simple way: early detection of diabetes, early detection of infections, early and aggressive approach on the diagnostic tools that are at our hand, and a correct interpretation of those reports also matters, because we can't be treating false positives and go on treating it. And I think we must congratulate CCI and our president, Dr. Krishna, for thinking of this topic and getting such fantastic logins of 1200 plus. We still are logged in. So I think with that, I thank the entire panel. Before I conclude, also make a point, and then we'll say, yeah.
Sir, excellent moderation. That is what I want.
Yeah, very good. Nitin sir, wonderful moderation. The way you like storytelling, we all enjoyed it. Lot of take-home messages. Samantha ma'am, thank you very much for your expert opinion. Raghukanth, Devi ma'am, and Saurabh. Wonderful. I learned a lot of things from your panelists.
So thank you very much, and we take your leave and see you soon in the next webinar. Thank you. Bye bye.
Thank you. Good night.
Yes.